So as central nervous system is made of brain and spinal cord. Anything other than brain and spinal cord is peripheral nervous system. So the brain and spinal cord, what does our brain, why do we need our brain? Of course, it is higher level function. Like if you look in our textbook, like what does a brain do? A brain like intellectual, memory, and on and on and on, emotion. So many different things is written in our book. I'm not going to repeat that, but in short, the brain is important for higher level thinking. And number two function of the brain is to control the autonomic nervous system. Autonomic nervous system, it is the motor system for the visceral organ. And the brain controls the endocrine system. And from the brain, all the cranial nerves come out directly from the brain, like 12 pairs, 12 on the right, 12 on the left, and then it will go and give like hypoglossal nerve, 12 cranial nerve, we supply our tongue. Like facial nerve, we go to the muscle of facial expression. So that sort of stuff. So the brain is important for these functions. Number one is higher level thinking. Number two is to control the autonomic nervous system, endocrine system. Of course, autonomic nervous system has its own control to some extent, but the brain also controls the autonomic nervous system. And the cranial nerve will directly come out from the brain to supply the other organs, such as facial muscles, tongue movement, hearing, and that's all. So spinal cord. So the brain, I believe you remember foramen magnum. Foramen magnum is the big aperture in the posterior cranial fossa. When you study the exoskeleton, you have been through and you have seen it already. I believe you remember foramen magnum. So above the foramen magnum, we will call it brain and brainstem. And below the foramen magnum, like once it's come through the foramen magnum, it is called the spinal cord. So what is the job of the spinal cord? Yeah, spinal cord is, all these motor fibers, like commanding fibers, coming from the brain, just let's say to the hand, it has to come along the brainstem, along the spinal cord, and only when it comes to the arm, it just comes out from the spinal cord to supply the hand. So let's say for those nerve fibers supplying the toes or feet, it has to come from the brain, down the brainstem, past the foramen magnum, in the spinal cord, come down here at the level of lumbar region, it leaves the spinal cord and run to the sole of the foot or tip of the toe. So it is for the motor and sensory movement and sensation for the lower part, everything up below the neck. And it is the pathway, of course, it is a freeway, like, connecting the brain and the every part of the body. And it is the center for the reflex. So for example, like micturition reflex, deglutition reflex, defecation reflex, all the reflex, it is the center. So reflex means like if the bladder get stretched or distended, filled with urine, the bladder will contract, the urine will pass. So without the higher level thinking, that is the spinal reflex. So like for those patients who has got long-term spinal cord problem, the spinal cord is damaged already. So anything below the spinal cord will come into reflex, like urinary bladder, like bladder get distended and bladder will contract, pass urine. So there is no control. So that is what we call, these are the functions of the spinal cord, and above is the function of the brain. So which is really important. And if we think about the brain, what is the relationship between brain and mind? I'm not sure what do we mean by mind is. Is it what we are trying to say like emotion or, whatever memory or yes, but the brain is a substance and the emotion or memory, these are the functional aspect which the brain carries. So have a look at this, this website, like American Association for Advancement of Science. Who we are, where do we come, what are we thinking, why do we think like that? So yes, have a look. And of course, depending on your culture, religion, background, and you yourself, we control a lot of emotion in your mind. And that is very difficult to understand. But what we understand, let's talk about what we understand. So this is the cross section around here, the vertex, tip of the head here. This cross section is shown here. This is the right side of the brain, and this is the left side brain. And we have the covering. Of course, if we shave our hair, there is no more hair. And we have our skin here, skin for the scalp. That is the outermost layer. So if we go deeper, if we remove the scalp, then we will get to the periosteum around the bone, so which covers the skull bone, which is called the cranium. So cranium bone, skull bone is covered with the periosteum. Of course, on top of that, we have our skin and muscle for the cranium, which is what we call the skin of the scalp. Yes, the scalp. And if we go deeper, we will have dura mater, arachnoid mater, and pia mater. So the way I try to remember is DAP, depth, dura mater, arachnoid mater, and pia mater. Of course, dura mater is outermost, pia mater is innermost. If you look at the arachnoid mater and pia mater, look at that. Pia mater is this light yellow color here. Pia mater is very thin and flimsy layer, which is stuck to the brain substance. Therefore, if you want to split the pia mater from the brain substance, I don't think you will be able to do that because it will be so difficult and you will damage the pia mater or the brain substance when trying to do so. But of course, there are two layers. The brain substance is here and the pia mater is above covering. And the outermost layer is dura mater, which is just underneath the cranial bone, skull bone. And dura mater has two layers, which is on the bone side, it is called periosteal dura mater. And on the inner side, it is called meningeal dura mater. And number 3 layer is arachnoid mater. So arachnoid mater is between the pia mater and dura mater. So DAP, I want you to remember DAP, depth. DAP depth, so dura mater, arachnoid mater, and pia mater, which is underneath the cranium skull bone. Of course, dura mater has 2 layers, periosteal, because it is on the side of the bone, so periosteal dura mater, and meninge on the meninge side, so meningeal dura mater. And look at this, guys. If you look at that, in between the pia mater and the arachnoid mater, so arachnoid mater is this pink color, and pia mater is here, the yellowish color. In between the pia mater and arachnoid mater, we have blood vessels. So this diagram is very intentionally drawn these blood vessels in between the space between the arachnoid and the pia mater. Because it is underneath the arachnoid mater, so it is just beneath the arachnoid mater. So We call this space subarachnoid space. Yes, the space between the arachnoid and the pyometer, which is underneath the arachnoid, and therefore we will call it subarachnoid space. So if there is any blood vessel damage, like blood vessel aneurysm, like arterial aneurysm, which sometimes called subarachnoid hemorrhage. So usually ladies, especially in their 45, 50, 55, that sort of age, sudden onset headache, and they will come with the headache. And the main complaint is, my worst headache in my life. I've never had this sort of headache before. Then that strike your mind. Can it be subarachnoid hemorrhage? Because the blood inside the brain is very irritant, and therefore they will carry severe headache, worse headache in their life. They don't like the light, which is called photophobia, and their neck will be stiff, which is what we call meningism, because the blood inside the brain, which is in the subarachnoid space, will circulate, and that will be very irritating. So, that is why we need to remember the blood vessels. They are underneath the arachnoid meter, in between the arachnoid and pyometer. This space is what we call subarachnoid space. If you look at the dura mater has two layers. On the bone side, it is called periosteal dura mater, and on the other meningeal side, it is called meningeal dura mater. Look at that here, guys. The periosteal and meningeal dura mater, they are pretty fused here. But in the center, they split. Look at that, they split. And by splitting, they are creating a cavity which is filled with blood, which is what we call venous sinuses of the cranium or the brain. Like the periosteal dura mater and the meningeal dura mater, they split to form a cavity which is filled with the venous blood, and that venous blood is called the venous sinuses here, sinus. So this is in the center, in the sagittal plane, therefore we will call it superior sagittal sinus. Because of course it is in the sagittal plane, it is above everything, so it is superior sagittal sinus. And this meningeal dura mater just come down in between two, right side of the brain and left side of the brain. They fuse with the opposite side here, and they become a thick sheet, which is called the falx cerebri. Falx cerebri, in between the two cerebral hemisphere. This is the right cerebral hemisphere, and this is the left cerebral hemisphere. So yes, I hope you are following. Let's go back again. If we shave our hair and we can touch the skin for the scalp here. And after the skin, we have the periosteum and the bone cranium. The bone is covered by the periosteum. And underneath the periosteum, we have three layers: DAP, dura mater, arachnoid mater, and pyometer. The space between the arachnoid and pyometer is called subarachnoid space. And we can see the dura mater has two layers, periosteal on the bone side, and on the other meningeal layer side is called meningeal dura mater, which split to form the venous sinuses. And this is what we see. So this is a brain surgery, like, put the patient on the table, just cut the skin. So the skin have been lifted away, and now we can start seeing the cranial bone and its periosteum. So the scalp here, which has been lifted up. So this is the very first step of the craniotomy. Cranial being Head otomy mean opening, craniotomy opening the skull. So yes, let's have a look at that again. Like, you know, the hair here, the hair we have, which we here, underneath the hair and the skin, we will have the periosteum and the cranium here. So scalp, that is what we call scalp here. So SCALP, scalp. So it is a acronym. So the skin for the brain has a few layers. Therefore, we call it scalp. I mean, how many layers we are going to get? 1, 2, 3, 4. P is stand for the periosteum. So the skin and the periosteum is called scalp. So skin, the scalp of the skin, which we have hairs. Yeah. So number 1 as C stands for cutaneous tissue, subcutaneous tissue. So underneath the skin, we will have subcutaneous tissue. A stands for aponeurosis. Look at that. Skin, subcutaneous tissue, and the white layer is called aponeurosis. Aponeurosis, I believe you remember epicranius, you know, like forehead muscle and the back muscle, occipital muscle, epicranius muscle, and epicranius aponeurosis. So that is aponeurosis. So skin, subcutaneous tissue, which stands for C. A stands for the aponeurosis. L stands for the loose connective tissue. This yellow loose connective tissue. And P stands for the periosteum of the skull. So that is why when we say scalp means it is an acronym for the skin of the skull, subcutaneous tissue of the skull, aponeurosis of the skull, loose connective tissue of the skull, and the periosteum. Underneath the periosteum, we have our cranial bone, which is here, double layer. Yeah, in between these spongy bone, 2 cortical bone, in between, there will be a spongy bone, and then meninges here. Outermost meningeal layer is, that is what we call dura mater. Dura mater has 2 layers. On the cranium side is called periosteal dura mater. On the other meningeal side is called meningeal dura mater. They are stacked on the every part except in the center, which split to form the venous sinuses. So don't forget, what do we mean by scalp? ALP, scalp. S stands for the scalp skin. C stands for the cutaneous tissue. A stands for the aponeurosis. L stands for the loose connective tissue. And the P stands for the periosteum. So that is scalp. You have seen this diagram already, like when we do the axial skeleton. So the brain is encased, or brain is inside the skull bone, which is what we call the cranium. Look at that. On the forehead here, we have the frontal lobe. Yeah, so the frontal lobe, we all know that. At the base of the posterior cranial fossa, we have the cerebellum. Directly opposite to frontal lobe, in the occiput, we have the occipital lobe here. So if you look at that, occipital lobe will be here, and the cerebellum will be here, and temporal lobe is just around the ear region. So I hope you remember the very thin temporal bone and very petrous temporal bone, which is really hard for the inner ear, and the very thin temporal bone, which is what we call squamous temporal bone, which is just above our ear. So this temporal bone, underneath the temporal bone, we have the temporal lobe of the cerebrum. So I believe you remember many temporal. Like now you see the temporal lobe of the brain. You have seen the temporal temporal bone of the cranium. And on top of that, we have the temporalis muscle, which is one of the muscle for mastication. So yes, that is, that is the way we put our brain inside our cranium. And if you look at the brain, when we say brain means it is a little bit loose term. If we are serious, we have to call the brain is made of cerebrum, so the whole frontal lobe, right, premotor cortex, motor cortex, occipital lobe, temporal lobe. That is what we call cerebrum. And we have underneath the cerebrum in the posterior cranial fossa, we have the cerebellum. Inside here, we have an area called diencephalon. And after the diencephalon, the brain will become a longitudinal structure, which is what we call the brainstem. The brainstem consists of midbrain, pons, and medulla oblongata. So that is a pretty, important anatomy. So if you anatomically, divide the brain, you will have to say, hey, the brain is made of cerebrum. Cerebrum is the whole brain here. And cerebellum is the little portion here, just in the posterior cranial fossa, underneath the occipital lobe. In the center of the brain here, we will have the diencephalon, and which will extend down, the brains will extend downward as a little tubular structure, which is what we call the brainstem. The brainstem is made of midbrain, pons, and medulla oblongata. Midbrain, pons, and medulla oblongata. Of course, we have to remember these structure because our vital centers like respiratory center, like the cardiac center, yes, they are in the midbrain, in the brainstem, sorry. So I hope you remember this diagram now. And let's move on and let's have a look at the real brain. So this is, what we saw. Yeah, so this diagram is the same like this diagram. So this diagram here, the same, like the brain cerebrum, and underneath here in the posterior cranial fossa, we will have the cerebellum. And now in somewhere around here in the center, we have diencephalon, and the brain will continue as a tubular structure, which is called the brainstem. The brainstem is made of midbrain, pons, and medulla oblongata. Okay, let's look at the cerebrum, C-E-R-E-B-R-U-M. Cerebrum is made of frontal lobe. Look at that frontal lobe, which is such a big lobe here. Look at the parietal lobe here. This is the parietal lobe. Look at the occipital lobe in the back, which is in the occiput region, and temporal lobe here. Temporal lobe in the temporal region, which is covered with the squamous temporal bone. So frontal lobe in the forehead, occipital lobe in the occiput region. On the temporal region, we have temporal lobe, and just the parietal lobe you need to remember, which is between the frontal lobe and the occipital lobe. And this is the lateral view from the side. So now if you look at the brain from the top, then we will see the right cerebrum hemisphere and left cerebrum hemisphere. In between, there is a fissure, which is a splitting point, which is what we call the longitudinal fissure. Of course, it is running along the anterior to posterior. And therefore, here, look at the longitudinal fissure. Therefore, we will we call it longitudinal fissure. And now you can see the frontal lobe, parietal lobe, and occipital lobe. So this is the left brain from the lateral view. We are looking from here. So yes, if we look at this brain from the lateral side, we will see this picture. And I want you to remember the frontal lobe, parietal lobe, occipital lobe, cerebellum, which is just underneath the occipital lobe, and we have the temporal lobe here. And after that, we will have the brainstem. So now we are going to look at the right brain from the interior side of the right brain. Yeah, so we will look at this brain from here. And that is what we see here. So the frontal lobe, parietal lobe, occipital lobe, and cerebellum. Look at the cerebellum, guys. Cerebellum. What does it look like? It looks like a cauliflower, isn't it? Just split in the half. Split the cauliflower, and if you look at that, it looks very much like cauliflower. Look at the brainstem. Look at the brainstem here, which is made of midbrains, pons. Look at the pons. This must be midbrain and medulla oblongata. Midbrain, pons, and medulla oblongata. That's brainstem. And diencephalon, which will be here. And this is the frontal lobe, parietal lobe, and occipital lobe. That's, you know everything here already. Temporal lobe, we are looking from inside of the temporal lobe, which is not very easy to see now. And from this diagram, what I want you to remember is this here, this one structure. Its consistency is very different from the brain substance here. Look at that. This brain substance and this brain here is very different. This is what we call corpus callosum. Corpus callosum, corpus callosum. Look at that. Corpus callosum is the white matter of the brain, which is connecting the right side of the brain and the left side of the brain. So this corpus callosum is attaching two cerebral hemispheres. So this corpus callosum from the right brain, we go to the left and connect the left brain and the right brain. So that is why the corpus callosum is important. And underneath the corpus callosum, we have a little cavity. We have created a little cavity. That is what we call the ventricles. Of course, you know, you have seen ventricle means chamber of the heart. We have four chambers, four ventricles, and two ventricles and two atrium in the heart. Now we are seeing the one ventricle in the brain, which is filled with the cerebrospinal fluid. And these ventricles, they are called lateral ventricle. So now the brain, the diencephalon, cerebellum, and the brainstem, which is made of midbrain, pons, and medulla oblongata. So this medulla oblongata became tubular structure, and once it's go through the foramen magnum, once it's go through the foramen magnum, we will call it spinal cord. Yeah. So the spinal cord. Spinal cord start from the foramen magnum and it will run down here. So spinal cord at different level of the spine, it will be named in the neck region, cervical region, it is called cervical region of the spinal cord, thoracic region, lumbar region, and usually around lumbar 1, lumbar 2 level, like in adults, this spinal cord usually terminates, and then this one single thick nervous structure will split into multiple fibers, which looks like a tail of a horse, and therefore we will call it cauda equina. Cauda means tail, equina means horse, cauda equina horse tail, which is the multiple separation of the one and single solid spinal cord division. So yes, in the neck region, we have cervical spinal cord, thoracic region, thoracic level spinal cord, lumbar region, lumbar level spinal cord, and finally become split into multiple fibers, which is called horse tail. In other words, cauda equina. And at every level, like at the neck level, the nerve from the spinal cord will come out right and left. In the thoracic region, the nerves from the spinal cord will come out in right and left. In the lumbar region, the same. In the sacral region, like as you can see, multiple fibers just split out and spread like that. That is our spinal cord. And when the spinal nerves come out from the spinal cord, look at that. This is the, let's say, the end of the spinal cord, which is what we call cauda equina, or it's written here, cauda equina here. And the nerve come out here to the right, nerve come out here to the left. Nerve come out here to the right, nerve come out here to the left, the same thing on and on and on. But what we need to remember, what we need to take from this diagram is, if you look at that, this is the lumbar 5 vertebra. This is the disc between lumbar 4 and 5. And this is the lumbar 4 vertebra. And this is the lumbar 3 vertebra. So lumbar 3 vertebra, intervertebral disc. Lumbar 4 vertebra, intervertebral disc between lumbar 3 and lumbar 4 and lumbar 5. And this is the lumbar 5 vertebra. And these are the pedicles from the vertebra, pedicles, pedicle, and pedicle. So L3 pedicle, L4 pedicle, and L5 pedicle. The way the nerve root come out from the cauda equina is L3 nerve root come underneath the L3 vertebra. L4 nerve root come out underneath the L4 vertebra. And L5 nerve root come out underneath the L5 vertebra. So that arrangement will become important, when somebody has got disc prolapse and which area the patient is going to get pain. Let's say if a patient has got disc between 3 and 4 prolapse, the patient will complain of pain or sciatica type pain in the lumbar 3 distribution or lumbar 4 distribution, but it is unlikely to be lumbar 5 distribution. So that's the way the spinal surgeon or neurosurgeon has to calculate what the patient say and what they see on the MRI scan. They will calculate whether it is worth an operation or not. It is because of this relation. But what I want you to remember is lumbar 3 nerve root come off underneath the lumbar 3 pedicle. Lumbar 4 nerve root will come out from the lumbar 4 vertebra. Okay, we will come back there again. Yes, just keep going with the slide here. Look at that. This is the way, all the spinal nerve come out from the spinal cord. Look at the blue color, which is cervical spine, the green color, which is thoracic spine, the yellow color, which is lumbar spine, and the rest sacrum and coccygeal region. So from the blue cervical nerve come out right and left. The green thoracic spinal nerve come out right and left here. And yellow and cauda equina become multiple. So if you look at that carefully, again, this diagram is very precise, I have to say. This is the cervical 1 vertebra. This is the cervical 1 vertebra. This is the cervical 2 vertebra. And the nerve root for the cervical 1 vertebra comes above, look at that, above the cervical 1 vertebra body. The nerve root for the cervical 2 come above the cervical 2 vertebra body. Three nerve root come above the cervical 2 vertebra, which is different from what we said from the previous slide. And finally, 7 cervical, look at the 7 cervical nerve root come above the 7 cervical vertebra, and there is one extra. So look at the C8, 8 cervical nerve root. We only have 7 cervical vertebra, but for the nerve root, we have 8. That's why the 8th cervical nerve root come underneath the 7th cervical vertebra. And since then, you know, we will have all the nerve root come underneath the vertebral body or pedicle. Thoracic 1 underneath the thoracic 1 vertebral body or the pedicle. Thoracic 2 come out underneath the thoracic 2 vertebral body or the pedicle, and on and on and on. And finally, when we come to the lumbar 2, lumbar 3, lumbar 4, so lumbar 3 nerve root come out below the body of the vertebra, below body and the pedicle of the lumbar 3 vertebra. This is what we saw here. So we know that we have 7 cervical vertebra, but we have 8 nerve roots from the cervical spine. We know that we have 12 thoracic vertebra and we have 12 thoracic nerve roots, 12 pairs, you know, of course, right and left. And for the lumbar, we have 5 lumbar vertebrae and we have 5 lumbar nerve roots. And for the sacrum, which is fused, but there are total 5 sacral vertebrae, and we will have 5 sacral nerve root, and we have the coccygeal nerve root. So that is our spinal cord. That is the general anatomy of the spinal cord. I hope it is not too confusing. So there is a difference between the number of the vertebral body and number of the spinal nerve roots pair come out, because cervical vertebra, we only have 7 vertebra, but we have 8 cervical nerve roots, and therefore these arrangement happens. So I want you to take it. It is not important for the exam, or might be a little bit 1 or 2 questions, nothing more than that. But with this knowledge, you know, you will have to walk with this knowledge for the rest of your life, as long as you are doing the anatomy or anatomical related medical specialty like nursing, radiology, like physical therapy, you know, or medical school. You have to grab this knowledge. Yes, I appreciate that. You know, I forgot when I was medical student. I study it, I forgot. Then I read it again, I forgot, I read it again. So that's the same, but at least we need to have a concept that, you know, these nerve roots, there is a disproportion between the spinal nerve root, the number of spinal nerve roots, and the number of cervical vertebra. Yes, let's look at this again on an MRI scan. Let's look at the guy on the MRI scan. Look at that. This is what we see. Yeah. So this is the MRI scan, which stands for magnetic resonance imaging. MRI. These are the vertebra. This must be the sacrum. This is the first sacrum, second sacrum, third sacrum. This must be lumbar 5, 4, 3, 2, 1. And this is the spinal cord. And this must be the cauda equina. spinal cords usually end at the level between the L1 and L2 vertebra. So, and you can see the cerebrospinal fluid, which is white here. Depending on the signal the MRI scan take, the fluid can be white or the fluid can be black. And this is T2. MRI scan has like basically T1, T2, proton dense, so that series. So now this is T2, CSF is white, the spinal cord is black here. So if you don't know how to look at the MRI scan of the spine, just try to interpret the vertebral bodies, like this must be sacrum, so this must be lumbar 5, 4, 3, 2, 1. Try to find the yellow fluid, white fluid, which is loss of water, therefore it is white. That is T2 imaging. Like the spinal cord substance itself is black here and become multiple cauda equina. So this MRI scan looks pretty good, pretty pristine. If you look at this MRI scan, oh, here again, like the lumbar lordosis, normal lumbar lordosis is there, nice and smooth. Vertebral body, anterior surface are in continuity, vertebral body, posterior surface are in continuity. So if you look at this MRI scan and this MRI scan, you can see a step here. So this is the sacral 5. There is a step, lumbar 5, which means lumbar 5 is going backwards, retro. That is what we call retrolithiasis. So the lumbar vertebra is going backwards in relation to the sacrum, and therefore you can see a step here. The sacral vertebra is coming here, and the step here, go back here. So that's why, look at that. Look at the disc here, intervertebral disc, yeah? Nice and shiny and very high intervertebral disc, good intervertebral disc, good intervertebral disc, good intervertebral disc, good intervertebral disc. But here, between lumbar 5 and sacrum 1, the intervertebral disc has narrowed. It is degenerative intervertebral disc, and the lumbar 5 vertebra is going backwards. So that's why if the patient say, hey, I got back pain, where is it? Is it here? Yes, it is not surprising, yeah, because the radiology MRI scan image equates what the patient see. So let's say if this patient, which is normal MRI scan, say, hey, I have got back pain, we will think twice whether this patient is just making a fake or is he really having pain, which we cannot see from this MRI scan. So this is a very normal MRI scan. This is a very normal MRI scan, nice and smooth lordosis, lumbar lordosis here. And the discs are high, the discs are well filled with water, and the posterior margin, anterior margin of the spine is good. Here we can see a little step here. That is a problem here. And the disc is fully degenerative. Yes, let's moving. So this is the way, the nerve roots come out from the spinal cord. So this is the lumbar 1 vertebra, lumbar 2 vertebra, lumbar 3, lumbar 4, lumbar 5, and this becomes sacrum. So as we say, like starting from the C1, the spinal nerve root just come underneath the associated vertebral body's pedicle. So this is lumbar 1. So underneath the lumbar 1 pedicle, the lumbar 1 nerve root will come out. This is lumbar 2. So underneath the pedicle of lumbar 2 nerve root will come out. This is the lumbar 3. Underneath the pedicle of lumbar 3 nerve root will come out. This is the lumbar 4. Underneath the pedicle of the lumbar 4 nerve root will come out. And this is the lumbar 5 vertebra. And this is the pedicle of the lumbar 5 vertebra. underneath it, lumbar 5 nerve root will come out. So I'm just trying to make you see, you know, like make sure you see from different angles, but just talking the same topic. So yes, I hope it is not too confusing. I hope it is not too confusing. And, you know, as I say, like, you will forget it, I will forget it. We have to read it again. So repetition is really important in anatomy because these are the way it is constructed. Our human body is constructed. So now we are seeing the nerve root coming out from the spinal cord underneath the associated vertebral body pedicle. So if we just try to trace back here, so now what I'm going to do is I'm going to trace the nerve root and go into the spinal cord where it came out. So look at that here. So this is the spinal cord, and this is the nerve root come out. And as we know, we have the anterior root and posterior root. And posterior root is for sensory fiber going in from the posterior root, and anterior root is for the motor fiber. Here, anterior root and the posterior root. And these posterior roots, when they go into the spinal cord substance, they become multiple small little rootlets here. So look at that, you know, it is not like just one single structure going into the spinal cord substance. No, it is splitting into multiple small little rootlets. So when they go into the spinal cord, they are multiple small little rootlets. And when they come out, these multiple small little rootlets merge and fuse to form the one anterior root and posterior root, and finally they will become the spinal nerve. As we know, anterior root is for the motor and posterior root is for the sensory. And we know that spinal cord cross-section, we have the white matter and the gray matter. Gray matter is a H shape, and the rest is the white matter. Gray matter is H shape, white matter is here, white colored, white matter. And in the center, there is what we call central canal. In the central canal, we will have cerebrospinal fluid just circulating around our body. Right, so this is now we go to the spinal cord, which is in the spinal canal inside the posterior to the vertebral body, in between the pedicle and lamina. I believe you remember that. Now look at that. This is the vertebral body. This is the vertebral body. Anything going out from the vertebral body is called pedicle, and fusing in the center is called lamina. So lamina and pedicle, we create a spinal canal. Inside the spinal canal, we have our spinal cord. From the spinal cord, anterior, posterior roots go in for the sensory, and anterior root come out for the motor. Combination of the anterior and posterior root is called spinal nerve. And the spinal nerve, it is like that. We will have right and left. These small rootlets will fuse to form anterior roots. Posterior roots, before it goes into the spinal cord, it will branch into multiple. Combination of anterior and posterior spinal root is called spinal nerve. In the posterior sensory, we have the dorsal root or posterior root ganglion. And this spinal nerve will come out from the in between the bone, as the lumbar 2 will come out beneath the pedicle of the lumbar 2 vertebra and lumbar 2 vertebra. And finally, yes, in the lumbar region, that is the way they come out. That is the way they come out here. So I hope you understand the way, you know, the spinal cord sitting inside the spine, inside the spinal canal, and then the ways the spinal nerves are coming out. And from the cervical region, we have 8 pairs of cervical nerve roots. In the thoracic region, we have 12 pairs of cervical nerve roots, spinal nerves. And in the lumbar region, 5, sacral region 5, and in the coccygeal region, there will be 1 coccygeal nerve root. So now if you feel okay, let me show you the other. So this is from the sacrum. So in the sacral region, like 7 fibers from the lumbar 4, lumbar 5, from the sacrum, like sacral 2, 3, 4, 1, 2, 3, like all these spinal nerve roots, they come out and march together to form the sciatic nerve. So you remember the sciatic nerve, which we saw in the muscles of the lower limb. Look at that. Sciatic nerve is the largest nerve in our body, and it is a very long nerve here. It came out from the spine, sacrum. So it is coming from the lumbar 4, 5, S1, 2, 3, and they will finally fuse together to form the sciatic nerve. Sciatic nerve will divide into the common fibula or common peroneal nerve. So here in this book, they like the name common fibula. It is identical to common peroneal nerve, and it will just another branch will go down directly as tibial nerve. Of course, you remember the popliteal fossa in the back of the knee, which is a diamond-shaped structure. So therefore, injury into the popliteal fossa is really important because we have the big sciatic nerve division, which is the tibial nerve and the common peroneal nerve, common fibular nerve is just there. And if you look at that tibial nerve, where is tibial nerve here? Yes, tibial nerve we divide into, we become the deep fibular nerve. We give it, common peroneal nerve, we common, so it is made of the superficial and deep fibular and superficial fibular nerve. We divide common peroneal nerve. And tibial nerve, we could keep going, and then we go behind the medial malleolus here. So like here, tibial nerve and common peroneal nerve. Common peroneal nerve is, the nerve root origin is 4-5, L4-5, S1-2. Tibial nerve is 4-5, S1-2 plus 3. So that is the root value for this sciatic nerve. So yes, it is going far, and I hope it stay, you can take it for another like 4 or 5 minutes. So let's say if we make a cross section of the sciatic nerve, what are we going to see? This is what we will see if we do the cross section of the sciatic nerve. So I believe we have seen this diagram already. So a nerve is made of axon, which is surrounded by the myelin sheath. And this axon and myelin sheath will be further surrounded by the endoneurium. So this endoneurium packed axons all around together, a bunch of endoneurium covered axons, they are called, and which is covered with another sheet. That is what we call the fascicle. The covering for all the bundles of the endoneurium covered axon, it is the perineurium, and multiple perineurium packed nerve fascicles, they are enclosed in the epineurium. It is the same like our muscle. You remember endomysium, perimysium, and epimysium. The same thing, epineurium, perineurium, and endoneurium. So the blood vessels, look at that, the arteries and veins, they are running in between the vesicles. Vesicles is the bunch of the axons which is covered with the perineurium. So that is the cross section of the nerve. I mean, yes, for the sake of anatomy, just study it. But you know, I mean, early stage of your further career, it might not be this important. But when it comes to your later, you know, advanced career, you will gradually have to know as well. Like when you are doing for the nerve repair, nerve reconstruction, then you will have to think about whether you want to stitch it back epineurium to epineurium. That is what we call epineurial repair. Or if you want to be more detailed, you repair the nerve, cut nerve from one side and other side, like you repair the perineurium repair. So that's the way, you know, your knowledge will gradually grow. But at the moment, hey, just forget about that. It is not a big deal. Let's see. So now look at this diagram here. I hope you remember when we talk about the embryology, like we have a neural tube. Yeah, the name come back here, neural tube. That is a little neural tube here, anterior and posterior. This neural tube at many different levels, it will just dilate here, and dilate here. And that happened at 4 weeks. And these dilatation will gradually dilate more and more and more, and finally become the brain. So telencephalon, diencephalon, and mesencephalon. So don't worry. I mean, it is, you know, it is just for the sake of completeness. It is not really I appreciate that if we really learn by heart, we will not remember. But at least you know there is some relationship between our cerebellum, cerebral cortex, diencephalon, brainstem, and where do they originate from? So yes, the brain and the spinal cord develop from the neural tube. Neural tube will gradually expand. Neural tube will expand at different level, and finally the top or most rostered expansion become 1 and 2. That is what we call telencephalon, which will become the right cerebrum and the left cerebrum. Diencephalon, that's what we are talking about. Diencephalon means thalamus, hypothalamus, and epithalamus. So the brainstem, mesencephalon. Brainstem, metacephalon, myelencephalon. So midbrain, pons, medulla oblongata, and finally that will become the spinal cord. Yes. Okay, then what I would do, I will stop for about 15 minutes, and we will it's like 10:59, so we will start in 11:15. Yeah, so go, you know, and you see things more and more already. That is exciting about life. If you keep studying, you will get more knowledge, more information. That is the beauty. So you have seen the lateral ventricle. Just underneath the lateral ventricle, you have seen the third ventricle. Where is the third ventricle? It is just around here. And what is the fourth ventricle, which is here? So the cerebrospinal fluid, CSF, is made inside the lateral ventricle. Which cells make the cerebrospinal fluid? Ependymal cells. You saw that, you know, those little cells like a cuboidal cell shape with the cilia, like little hairs, which we saw in the previous lecture. These ependymal cells make the cerebrospinal fluid, and it is created in the lateral ventricle. And finally, from the lateral ventricle, it will come down into the third ventricle. from the third ventricle, it will continue to drain into the fourth ventricle, and fourth ventricle, it will just spread outside around the brain and continue into the spinal cord in the central canal. So that is the flow of the cerebrospinal fluid. So yes, this diagram is very interesting. And of course, this diagram might be more interesting. Yeah, so what is this? This must be the fourth ventricle. What is this? This must be cerebellum, occipital lobe, lateral ventricle, and third ventricle is somewhere. Look at the here, you can see that from the lateral ventricle, the fluid is coming out into the third ventricle, and the fluid will keep going down here into the fourth ventricle. And finally, it will go around the brain or around outside of the brain, and it will go into the spinal cord in the central canal. So yes, it is beauty. It is beauty. Now we know that already. Yes, we will forget it. So what? That doesn't really matter. We will just go and read it again to remind ourselves. So now we are looking at the brain in a coronal section, and this is the right cerebral hemisphere. This is the left cerebral hemisphere. This is the falx cerebri. We can see the lateral ventricle, which is color with left. We can see the third ventricle. Now we can see third ventricle here, the fluid CSF, because MRI scan pick up the hydrogen ion from water. Water, CSF is mainly made of water. Water means hydrogen ion. Lots of hydrogen ions will be picked up, and the MRI scan will interpret this white fluid here. So these fluid phase structures inside the brain, right and left. This is the right lateral ventricle. This is the left lateral ventricle. From lateral ventricle, it will go into the third ventricle. From third ventricle, it will go into the fourth ventricle. Now, after the fourth ventricle, it will go all around outside the brain. Look at that. The outside of the brain here, is all covered with the white CSF. Look at that. That is a beauty. It is so exciting to see this diagram. Let me move on. So that's what we saw, isn't it? What is the big deal? No big difference at all. Yeah, so you can see the fluid around the brain, which is the CSF, fluid inside the brain in the cavities, which is CSF. So now I believe my students will be able to, talk at least some bullshit about these MRI scans of the brain. And the same, isn't it? Let's say now we are seeing the axial section. So we are cutting the brain in the axial section. So this is right side, this is left side, this is the frontal lobe, this is the occipital lobe. So we have seen the brain in three sections. This is sagittal section, looking from the side. This is coronal section, looking from the front. And this is the axial section, just axial cross section. And patient is lying supine. This is the right side, this is the left side, this is the frontal anterior, and this is the occipital posterior. And you can see the lateral ventricles here. And this is the ventricles here, anterior horn of the lateral ventricle, anterior horn of the lateral ventricle, posterior horn of the lateral ventricle, posterior horn of the lateral ventricle. Of course, you have to see, and this is the way, look at that. If you look at from the front coronal view or anterior view, the lateral ventricle, the shape of the lateral ventricle is like that. That is anterior horn, and that is there will be posterior horn, and there will be posterior horn, and there will be inferior horn here. So lateral ventricle has three horns. And it will just march together to form the dilatation, which is called third ventricle, and that will go into the fourth ventricle. Look at that, the connection between the third ventricle and fourth ventricle. the opening of the third ventricle into the fourth ventricle, it is called cerebral aqueduct. Okay. And the two lateral ventricles join together to come into the third ventricle. That is what we call interventricular foramen. Look at that. These names comes again and again. If we look from the lateral side, lateral ventricle, anterior horn, posterior horn, inferior horn, we drain into the third ventricle. Through the cerebral aqueduct, it will drain into the fourth ventricle. So yes, I know it takes time to absorb all these information, but again, like, it is repetition and some sort of understanding between connection of each and every structures. So let's move on to the next slide. Oh my God, what is that? That is the blood supply to the brain. So we are now looking from the right side of the body. You can see the arch of aorta here. So from the heart, the aortic arch come out. And as we know, the three big blood vessels arise from the arch of aorta. They are on the right brachiocephalic, and for the left common carotid and left subclavian. So on the right, common carotid and subclavian, they are together as brachiocephalic. And then brachiocephalic, brachio means arm, cephalic means head. So cephalic and brachio. The brachio for the arm, the artery will divide as subclavian artery. For the head, it will divide as common carotid artery. Common carotid artery will finally divide into external carotid and internal carotid artery. Look at the internal carotid artery here. Internal carotid artery will come into the skull, into the brain, a carotid foramen, you remember that, into the brain, and that will give blood supply to the brain. External carotid is mainly for the neck and the face. So external carotid is from outside, internal carotid is for inside of the cranium. Okay, so this is a very rough idea. I just want you to take the rough idea. And so from the common carotid, we divide into external carotid and internal carotid. External carotid is for the neck and the face. Internal carotid is for the inside, the brain structure. Look at that. This is so crazy. What do we mean by crazy? Look at that. Look at the internal carotid artery. So if you do not know, I want you to look for the internal carotid artery, which is here, internal carotid artery here. So we are looking at the base of the brain. This is anterior frontal lobe. This is posterior. We can see the cerebellum, and there will be occipital lobe. This is the right side. This is the left side. So we are looking at the base of the brain, and we are looking upwards. We are looking upwards. And this is the internal carotid artery for the right side, internal carotid artery for the left side. This internal carotid artery will give a branch, internal carotid artery will give a branch called anterior cerebral artery. So anterior cerebral artery from the left internal carotid artery. Here, from the right internal carotid artery, another anterior cerebral artery will arise. And they will go, because the name anterior, so it will go to the anterior or into the frontal lobe. Look at that. And these two anterior, right and left anterior cerebral artery will have connection. That is what we call anterior communicating artery. And this, the main branch of the anterior internal carotid artery will continue here as the middle cerebral artery. So if the question is, what is the fate of the internal carotid artery? inside at the base of the brain. Then the internal carotid artery will give a branch which is called anterior cerebral artery, which will run to the frontal lobe, and it will continue as the middle cerebral artery because it is running to the middle of the brain. And we will have a just anterior to the brainstem, we have the vertebral artery, so which is starting from the subclavian artery to left vertebral artery and right vertebral artery. They will merge together, and at the level of pons, look at that. That is what we call the basilar artery. So right vertebral artery, which is originated from the subclavian artery, and left vertebral artery combine together to form a bigger basilar artery. So basilar artery is running on the anterior surface of the pons. You can see the pon here, and finally divide into posterior cerebral artery and right posterior cerebral artery and left posterior cerebral artery. And these posterior cerebral artery will connect with the middle cerebral artery again. So now we form a little cycle of blood vessel at the base of the brain. That is what we call cycle of Lewis. Oh my God, another name. So this is what we call cycle of Lewis. So this is the right vertebral artery. This is the left vertebral artery. The vertebral arteries originate from the subclavian artery. Combination of vertebral artery, it is called the basilar artery. Basilar artery is just running on the anterior surface of the pon here. And the basilar artery will split into posterior cerebral, right posterior cerebral and left posterior cerebral artery. And this internal carotid artery will give a branch which is called anterior cerebral artery, which will run to the frontal lobe, and right anterior cerebral and left anterior cerebral. And this internal carotid artery will continue as the middle cerebral artery. So we are going to connect each and every cerebral artery. So right cerebral artery and left cerebral artery will be connected. That is what we call posterior communicating. And the posterior cerebral artery and middle cerebral artery will get connected. That is called posterior communicating. And okay, oh yeah, sorry, Kristen and Arturo, yeah.
I just have a question. Are these the arteries that are what cause an aneurysm? Are they involved in that?
That's true. You know, like they can get blocked or they can get rupture. Like for example, aneurysm, which is the definition of aneurysm is abnormal dilatation of the blood vessel. So if these blood vessels become dilated for many different reasons, because of the infection or fungal infection, or because of the aging process, or because that person is born with the connective tissue disorder, so that the tunica intima media adventitia is not good, then that blood vessel will gradually become dilated and they can get ruptured. That is what we call the, let's say, you know, if this basilar artery rupture, it is just on the pon. So look at that, the blood vessel from the basilar artery is going to supply the pon. So if these vessel rupture, then that person is going to die, very likely to die because brainstem stroke. And at the same time, if we have blockage or rupture of the anterior cerebral artery, then the blood flow to the frontal lobe will got damage. And that is, so these little, yeah.
Sorry, and what is it that causes a stroke? What's the difference?
So stroke is like, stroke which we can divide into two types. Mm-hmm. Stroke it is hemorrhagic or bleeding. The blood vessel rupture and bleed, no more proper blood flow, or the blockage of the blood vessel, so which is thrombotic. blood vessel become blood clot. The blood inside the blood vessel become clot, or little clot travel along and then block the artery, or like, cholesterol and then blood atherosclerosis, and then the blood vessel gradually become interior surface of the blood vessel become a block, like because of the cholesterol deposition and that sort of stuff. So that will be thrombotic stroke. So thrombotic means the blockage of the blood vessel. Therefore, no more blood flow to the particular part of the brain. So if we have blocked the anterior cerebral artery, we have blockage and no more disruption of the blood supply to the frontal lobe. So let's say if we have rupture of the anterior cerebral artery, there will be bleeding around here, and there will also damage to the blood flow, disruption of the blood flow to the frontal lobe. So there are two types of stroke: thrombotic stroke, so the blockage of the blood vessel, or hemorrhagic stroke. Hemorrhage means bleeding inside the brain. So hemorrhagic stroke is more severe, I think, because thrombotic stroke is the blood vessel just no more blood flow. Then there will be some collateral circulation to compensate. But the problem with the hemorrhagic stroke is there will be bleeding in the brain substance, around the brain substance. And that is another problem. There is a disruption of the blood supply as well as damage to the brain because of the bleeding. So it is more difficult to deal with.
Yeah, my dad had the hemorrhagic stroke a few years ago. And so I didn't know what exactly, I guess it was.
Yeah, so these blood vessel rupture. So my dad also has a hemorrhagic stroke. Yeah, so it is this hemorrhagic stroke is, it is pretty harsh, because just blockage of the vessel is fine, because it is contained. The problem is contained inside the blood vessel. But the rupture of the blood vessel is all the blood from the vessel come out at the same time, disruption of the blood flow again. So that is a pretty harsh process. On top of that, when we get old, we are taking like aspirin and warfarin and Epic-7 and many other medication. So that makes the bleeding even worse.
Right, because those are blood thinners.
These are blood thinners. So usually if the blood vessel rupture, the body homeostasis mechanism will try to control and then the rupture blockage and limit the blood flow outside the vessel. But because these are the blood thinners, so the body cannot really, act, because we have treated our blood to get thin and not to get clogged. So that is even worse.
I do know that they also took a piece of his skull off in the back to relieve the pressure from the stroke, and they didn't put it back on. No,
because we will come there in the later slide, because if you think about the cranium is rigid. Yes, skull bone is rigid. Inside the cranium, what do we have? We have the brain substance. We have the blood from the blood vessels, artery and vein, and we have CSF. So we have three structures inside a rigid box. So all these volume of the brain, or volume of the blood inside the blood vessel, or the volume of CSF, it needs to be constant. If anything increase, like if increased blood flow, or if the bleeding inside the brain, or if the brain substance increase, for example, brain tumor, or if the CSF is producing too much, like which is what we call hydrocephalus, loss of fluid inside the CSF, then the brain cannot cope, because it's a tight brain, cranium is a rigid box, and all these three as contents, brain substance, the blood in the blood vessel, and the CSF need to be constant. That is what we call Monro-Kelly doctrine. So if one is increased, then we have to release the pressure. So the easiest way is to just take the cranium skull out. So that way ease the pressure off, because it is no longer a tight, rigid box. And because at that point, the patient has stroke already, hemorrhagic stroke already, and their age is not favorable usually, and putting the skull flap into the brain to cover the brain is another big operation, which has got its own complication. Like it might not stick back together, you might get infection, and therefore risk and benefits. Usually we keep the skull in their tummy, Is that what they did?
No, I think they just left it out and closed him up, and he's just been healing ever since.
So yeah, so many times, like they tend to keep the skull bone inside the abdomen, just to keep it so that if the patients, especially younger patient, they are ready for another operation, if they are fit enough, then yes, we can take the skull bone from the tummy back into the brain and then just stick it back in.
Thing that's really interesting, just because it was 3 years ago now, and so he's still recovering from it. He still has some deficits, but I mean overall he's made a pretty miraculous recovery.
Okay, that's brilliant. That's good. So he must be pretty young.
Oh, 50 something.
Yeah. 54, okay, so
55.
Yeah, so that is very young, 50. That is very young. That's why he can stand this, because my father is about 86, 87, so he's not well. So yes, younger patient has better reserve, and therefore they can overcome a lot. They have much reserve. So this is the cycle of Willis we are talking about at the base of the brain. And that is the way we supply the brain, the brain anterior cerebral, posterior cerebral, and middle cerebral. Middle cerebral is just a continuation of the internecrotic artery, which is after giving the anterior cerebral artery. Yes, of course, the good thing about that is, if there is one blockage here, then the blood will be diverted from here to there and then go. That might be a good thing about, thrombotic stroke. Yes, that's the way, it's just like a cycle at the base of the brain. Arturo, I think, are you stay there?
Yeah, Professor. My question was, I don't know if you went over this, but is there such thing as having like migraines and due to bad circulation in the brain?
Migraines, yes, usually, they said migraine is the abnormal dilatation of the blood vessel. So let's say if this blood vessel going to the frontal lobe, it need to be like well-regulated caliber, isn't it? That's the way we control the blood flow to the frontal lobe, or the same like other vessels. Like migraine means abnormal dilate. The underlying pathology is inside the brain. These blood vessels are dilated. That's why, for the migraine patient, if we look at the anti-migraine medication, there will be like argometrine or something like that. They are for vasoconstriction. So migraine means the blood vessel get dilated. There will be more blood flow to the brain. And because it is, as we say, like Monroe Kelly doctrine, like we cannot cope with extra blood flow. We don't need that. If we get it, something will happen. Like we'll get headache. So that is one of the reasons for migraine. Of course, there will be many other reasons.
Oh, so like increased blood flow. So it's an excess of blood flow in the brain.
So yeah, abnormal dilatation of the blood. So which means, as you say, like excessive blood flow to that in the brain.
Okay, thank you, Professor. I was just wondering, I thought it was actually low blood flow.
No, it is like high blood flow.
It's high blood flow.
Yeah, high blood flow, like vasodilatation, and just like because of the vasodilatation, like, you know, the brain cannot go because too much blood is coming in. But the basic pathology of the migraine is a little bit complex, but that is one highest region. And therefore, if you look at the anti-migraine medications, many of them are like vasoconstrictors.
Yeah, it makes sense. Thank you, Professor. It was just, I was just wondering.
Yeah, it's good, you know, like good to think around.
Because yeah, because I thought my migraines were because I didn't have a blood flow. Yeah. But now it's like it could be caused by many different things, you know.
Yeah, of course, you know, emotional, again, like, yeah, some of the migraine will be triggered by emotional, but underlying pathology is usually vasodilatation. So if you look at the anti-migraine medication, like many of them are like vasoconstrictors that constrict the blood vessel. So now we are looking at the brain from the top. So this is the anterior, so this is the frontal lobe. This is posterior, so this must be occipital lobe. This is the right side of the brain. This is the left side of the brain, right hemisphere and left hemisphere. And now they are splitting this near the parietal region into two, a pink color anterior and purple color posterior. Yeah. So because the difference is pink color is more towards the frontal lobe and purple color is more towards the posterior occipital lobe. That is what we call the pink color area is called motor cortex, and purple color area is called sensory cortex. So we have, like on the right hemisphere, we have motor and sensory cortex region. And on the left hemisphere, we have motor and sensory cortex region. So let's pick up the motor from the right and sensory from the left. That is the brain area representation of the different parts of our human body. So for the motor, look at the area representation. Look at our face, such a big area occupying the brain, which means this large portion of the brain is used for face. Look at that. Look at the tongue. Tongue is also pretty big here. Look at our hand. Hand is very small, but it takes such a large area, surface area on the brain. Look at that, our lower limb, you know, our thigh, our leg, and our feet. They are, it is, you know, on the body, the lower limb, our lower limb, thigh, leg, and feet, they are nearly half of our body. But on the brain, its representation might be less than our face. That's why we can control our hands much.
Fucking liar. Hey, you liar. Are you hungry?
So that's why, you know, our hands, our face, we can move whatever way we like. Especially girls, you know, they do a lot of facial expression, which means like they must have a big representation on the brain for the face. Like look at our hands, you know, hands is just about this side, but it's occupied nearly the size of the face on the motor cortex. That's why we have a lot of controls with our hands. we do not have much control with our legs or the feet or the toe. Look at that. That is the area representation. So the bigger area we occupy in the brain, the better fine movements we can produce in our body. So that's why, you know, face has got big representation. Our hand has got big representation. The hip, knee, foot, and toes, they have very small area representation from the motor cortex. Therefore, we are not able to do like feeding and doing this with our toes. Yes, so the elbow, look at the elbow, it is very small. Shoulder, quite a bit. That's why we can do a lot with the shoulder. And the tongue is for sensation. So we can twist our tongue, flip our tongue, and we can do many different things. That's why it is pretty big. Tongue is a small structure comparing to the leg, you know. So the same thing like for the sensation as well. For the sensation as well, we have like our face has got big representation. Therefore, if we touch our face, we know we can differentiate quite a lot of sensation from the face. And look at the hand, you know, the hand is so sensitive. And even if you close your eyes, if you touch something, you know what you are touching because it has got big area representation in the sensory cortex. And look at that, you know, lower limb, like hip, leg, thigh, foot. Oh, foot has got a good sensory representation. Therefore, look at the difference between foot sensory and foot motor. Foot motor is very small. Therefore, you cannot do much with the foot. You cannot twist your toes in the way you like. But if you touch your foot, you are very sensitive because it has got big area of sensory representation in the sensory cortex. Yes, like the face, even the tongue, jaws, tongue, look at that. That is a big area representation. Therefore, if you eat something, you know the many different is sweet, sour, hot, whatever, like because you got a big sensory area representation in the brain. So yes, of course, motor is in motor cortex and sensory is in motor cortex, sensory cortex. We do have those in both right and left hemisphere. Of course, you know, this area representation, all the fibers finally, you know, march together. It has to go, twist and turn and back around here in the brain here. And then finally, they will travel inside the brain along the brainstem. And at the level of medulla, some of the fiber will cross to one side, some of the fibers will continue on its own. So that is what we call these motor fibers crossing here. Like generally 80% of the motor fibers from the right will cross to the left, 80% of the motor fibers from the left cross to the right, remaining 20% will continue at its own level. And finally, when they go to the lower level, they will cross. That is, these crossing at the medulla oblongata is called motor decussation. Decussation means crossing. So yes, finally 80% of this right hemisphere motor fibers will cross to the left at the brainstem level. Left will cross to the right at brainstem level. Remaining 20% will cross only at the level or just above the level where they need to go and supply. And this is what we call motor decussation. Yeah, and like look at that, like it has to go in between the like multiple like lateral ventricle and going in and twisting and turning around. So this is what we are going to see here at the base of the brain, and you can see the structure, which is pons. You can see the structure here. Now you know this is the temporal lobe. Now you know this is cerebellum. If you remove the cerebellum, you will see the occipital lobe. Now you can see the frontal lobe. Now you have an eye to see the cycle of Lewis. Cycle of Lewis, which is made of the internecrotic artery, which is divided into anterior cerebral artery and the middle cerebral artery, and you can see the posterior cerebral artery, which is the division of the basilar artery on the brain. There is no more basilar artery here. And now, you know, it is a bad timing when it comes to the near end of the lecture. Like, you know, we got these difficult diagram here. So the blood flow from the brain back to the heart, it is drained in a slightly different way. So from the brain substance, they will drain into the duravenous sinuses. Look at that. I believe you remember the superior sagittal sinus, which is a space between the parietal and meningeal layer of the dura mater. So dura mater has two layers, which is the parietal and the meningeal layer. That space is called the duravenous sinuses. This duravenous sinuses, the brain substance, will cross everything here, go into the duravenous sinuses, and finally, these venous sinuses will march and march and march, and finally we drain back into the we become the internal carotid, internal jugular vein, and we drain into the superior vena cava. Of course, there are many venous sinuses other than the superior sagittal sinuses, which we will talk in Monday's lecture, because if I talk that, it's too much for you guys. So now what I want you to show you is, I want to show you the CSF. What is this? This is the corpus callosum. Look at the corpus callosum. Underneath the corpus callosum is the structure which is connecting the right cerebral hemisphere and left cerebral hemisphere. Underneath the corpus callosum, we have the lateral ventricle. Lateral ventricle, look at that, going into the third ventricle through the interventricular foramen. Look at that, from the third ventricle, which is going into the fourth ventricle through the cerebral aqueduct. And finally, from the fourth ventricle, it will go into the central canal of the spinal cord, or outside of the brain and around the brain substance, which is called inside the subarachnoid space, and cerebrospinal fluid will circulate around the brain, and that will give a cushion to the brain, so that if the head is shocked, you know, it is not really shocked. It can take the impact because of the fluid and buoyancy of the CSF and blood, so that the brain should not get shocked directly by the external pressure. And the last slide, if I may. Look at that. You have seen this. You have seen this diagram already. The base of the skull, the frontal, and this is occipital, anterior cranial fossa, middle cranial fossa, posterior cranial fossa. Inside our posterior cranial fossa, we have the foramen magnum, the brainstem. Inside the cranium is brainstem. Once it's passed through the foramen magnum, it becomes the spinal cord. And you have seen this little structure, sella dasica, where we have our pituitary gland is. And we remember three apertures here. They are in the middle cranial fossa, three aperture. They look like lacerated, and therefore the name is called foramen lacerum. Look at that, it is like an oval shape, foramen spinosum, and very little tiny most lateral is foramen spinosum, and this is oval shape, and therefore we call it foramen ovale. And we can see the jugular foramen here, and we will see the internal carotid foramen somewhere around here. So this is the base of the skull, and all the brain cranial contents will leave the cranium through this aperture. So I'm going to stop here. because if I push too much, it's become more confusing now. Have you got any question?